Hi, everyone, and welcome to today's webinar. I'm with Rian Booker, actually, who's in the hematology and oncology group at Tom Baker Cancer Center in Calgary. So welcome, Rian. Thank you for accepting the invitation. So today's subject is about improving quality and quantity of life. What is the role of palliative and supportive care? So we'll see the difference between the two for the myeloma diagnosis. So before we begin, just want to make sure that you all consider this session today as positive. We know that anything related to palliative and a end of life is quite a sensitive topic, but today's session actually is more a way of understanding what's available as far as services and plan accordingly far away in advance. And also you need to remind yourself that the more knowledgeable you are, the more it reduces stress and anxiety. So before I let Rian present this subject for today, I will just share my screen for a few instructions for today's webinar. Bear with me for a moment. So you can all see my screen. Thank you, Rian. So, Karen Gravel, actually, I'm a regional manager regarding the education, but also community engagement at Myeloma Canada. So, I would like to thank our sponsors because without them, of course, we could not create those types of webinar and educational materials. So thank you to AbbVie, Amgen, Apotex, Binding Site, BMS, Forest, GSK, Janssen, Merck, Pfizer, Sanofi, and Takeda. As you can see today, we only have the two speakers on your screen, and you cannot activate your audio either. So the way we will interact for today, if you have questions or comments throughout the entire presentation, please feel free to ask your questions right on the spot so you don't forget them. If we have time, we will address those right away. Otherwise, we will keep a few minutes at the end of the webinar to answer all your questions. So if you're logged through your tablet, your phone, your computer, so you should be able to see a menu bar, and the Q&A is what we will use today to interact. So I will be monitoring that today for Rian and address your questions. And also we will be using one poll today to ask you for some feedback. So you should be able to see poll as well in the menu so that you can type in your answer. And if you are on your cell phone and you don't access the menu bar, sometimes you just have to swipe to get to a second window. Today's session is recorded, so if you go on the myeloma.ca website, you can press on Resource tab and you will access the educational videos. If you click on that, it will direct you to our YouTube page. You can go directly on YouTube as well and look for Myeloma Canada, and if you see the red flower, you're at the right place. And so you just have to click on videos or playlists. You have a lot of material there, all educational material related to myeloma. So side effects, meeting your pharmacist, any type of subject, all related to myeloma. And also, if you click on subscribe, the little cloud I circled. So if you hit subscribe, you will be notified every time we load new material. All right. Here we go. I'm sharing. Okay. Welcome, Rian.
Well, hi, welcome everyone, and thank you so much for the invitation to speak with you today. And I will just try to share my screen here now. And make sure the slides come up. Can you see the slides okay there now?
Perfect. Yes.
Okay,
Thank you.
excellent. Well, yes, thanks for the introduction. And as Corinne mentioned, today we're talking about a bit of what might seem like a difficult topic, but I'm hoping by the end of this presentation, you'll realize that palliative and supportive care are meant to add more support, another layer of support to your care and your treatment, and not just for the patient affected by myeloma, but also their family and loved ones as well. So briefly, I don't have any conflict of interest to disclose. I've received some funding for my PhD in research studies from nonprofit and governmental organizations, but no industry or conflict of interest sponsorships to disclose. As always, we want you to talk with your medical team before making any changes to your care. So this presentation today is intended just for educational purposes. And I'm happy to share slides. So please don't feel like you need to make notes or anything like that. I know this is being recorded, but I'm also happy to send you the slides if it would be helpful. So today I'd like to talk about what palliative care is, what it isn't, and how it can help after a multiple myeloma diagnosis, both for the patient and their family caregivers. To talk about some of the common palliative and supportive care needs that we see quite often with multiple myeloma, and to discuss the palliative care and supportive care resources that are available for patients and caregivers. So just some background about me. I started working in oncology even when I was an undergrad nursing student. I worked at the Cross Cancer Institute in Edmonton, Alberta, and I worked mostly in the inpatient unit then. And then after graduation, I worked in the chemotherapy or daycare unit and some of the outpatient clinics. I went on to do my master's degree with a focus of my thesis research focused on quality of life for patients diagnosed with multiple myeloma. And I obtained my nurse practitioner credential and moved to Calgary and started working in the Alberta Blood and Marrow Transplant Program in 2005, where I saw a lot of patients with multiple myeloma, among other hematologic malignancies. In Calgary, shortly after I moved, I met one of the very strong advocates for the myeloma community in Calgary. If any of you may have heard of Carol Westberg, and she and I created the first Alberta version of the walk and run back in 2009. It was the Multiple Miles for Myeloma. And it went on for, it still goes, it's still running, no pun intended, to this day, and raising funds and just, supporting patients and caregivers, and really, I think, increasing awareness about what multiple myeloma is. And of course, many of you might know then too, back when I would have started in oncology, so I'm talking, 2001, 2002, we didn't have as many treatment options back then for multiple myeloma as we do today. So I've really seen tremendous advances in the field of myeloma, and it's really quite encouraging. And now I'm back. So I've worked with the blood and marrow transplant program for about a decade, and then I started working with the palliative and supportive care program. And then I'm back now at with the hematology oncology group at Tom Baker Cancer Center in Calgary. The focus of my PhD research is on the integration of palliative and supportive care for patients with hematologic malignancies and those going through bone marrow or stem cell transplant. And it would have been, I guess, last year that I was invited to write an editorial about a paper that appeared in the Annals of Palliative Medicine about quality of life and supportive and palliative care for patients with hematologic malignancies. And so just to kind of set the stage, when we talk about, I think, the need for palliative and supportive care, we know that a cancer diagnosis, and especially a myeloma diagnosis, can result in a lot of different types of supportive care needs. So there can be needs related to the disease itself. So things like prognostic and illness understanding the treatment and the risks and benefits, home care support. Then there can be the whole physical side of things in terms of pain, fatigue, shortness of breath, weight loss, weight gain, feeling sick to your stomach and throwing up. There's also the emotional category, anxiety, depression, coping, the social aspect, so changes in roles, the impact on family caregivers, the impact on relationships. There can be financial issues. There's a spiritual and existential component as well that can be significantly affected. So we know that there are vast needs that can occur after a cancer diagnosis. And where palliative and supportive care can come in is addressing that multi-dimensional aspect, I guess, of suffering. So not just the physical side, because I think most people will recognize that these, while they're in little boxes on the screen right here, they're not so neat in real life, and they definitely will overlap. So if you're having a lot of psychosocial distress, that can influence physical symptoms such as pain, and vice versa. So we really need to be looking at the person and their family as a whole comprehensive unit, and not trying to just treat individual little aspects of what's going on, but really focusing on the whole person. And included in that whole person would be their chosen family as well. So I would say the palliative and supportive care needs after multiple myeloma really depend on where somebody is in the disease trajectory. So the needs will vary depending on, is it time of diagnosis? Is it during treatment? Or is it a period of follow-up after treatment? Or is it surveillance or observation? And then also end-of-life care. So recognizing that end-of-life care is just one tiny part of this. But at diagnosis, a lot of patients with multiple myeloma will present with fatigue because they're often quite anemic, so their hemoglobin is quite low. So profound tiredness and weakness. There can also be significant bone pain if there are any lytic lesions or bone disease at time of diagnosis. If there's hypercalcemia or high calcium levels, there can be some confusion or even delirium that can be happening. And then during treatment, of course, that can be anything from nausea and vomiting, neuropathy, peripheral neuropathy affecting fingers, toes, and elsewhere. There can be constipation and diarrhea. It's difficult. We very often are navigating both ends of that trajectory. So it's difficult to try to get right in the middle. So sometimes we have medications that cause diarrhea. Sometimes we have medications that cause diarrhea or constipation. And magically, they don't cancel each other out. You would hope that they would, but they don't always. And so often it's really difficult to try to manage bowels, things like shortness of breath, impact on physical function as well. And then all the different medications we use to treat the side effects can have side effects of their own too. So it can become a little bit of a vicious cycle. And then after treatment and during follow-up, those are times when we might see things like peripheral neuropathy surfacing and just wanting to monitor that. There can also be concerns about fear of recurrence or fear of progression. And so the psychosocial needs can also be quite pronounced. And then at end of life, that would be, again, where we'd focus very carefully on trying to manage any physical symptoms that arise, but also any psychosocial and spiritual or existential concerns or symptoms that might arise. There's also a practical and informational component that's really important too. So understanding about the disease and treatment, and understanding, what the trade-offs might be for different types of treatment and things like that. Myeloma Canada has got some great worksheets where you can take notes and you can compare and contrast different treatment options and find out which one is the best fit for you. And then also talking about goals and wishes for the future is also, I think, a really important part that we often neglect. It's a really important part of all of our care that we should all focus on. But again, because there's some negative connotation and perhaps some stigma associated with that, we just don't like to think about if things might not go well. But it is easier to make those decisions when things are going well and avoid making those decisions at a time of crisis. So specifically, some of the work that I've done, and this is unpublished data as yet, but one study I've done for part of my PhD research is to look at a large data set of patients who completed what we call in Alberta the Putting Patients First a survey. So it's a modified Canadian problem checklist, and the ESASR, which I think the ESAS is probably something that many people are familiar with. It asks patients to rank their symptoms from on a scale of 0 to 10, with 10 being the worst. And you can also write in an additional symptom if there is another symptom that's not listed of the 9 that are included. And this data set, as I said, was quite large. So it was almost 30,000 patients. Of that, there were just over 6,000 with blood cancers. And of that, about 1,000 with myeloma. And then I also did a deeper dive to look at the patients who died during a 6-month period, within 1 year of completing the patient-reported outcome measure. And so that, again, in that cohort of patients who passed away, there were a good chunk of patients with multiple myeloma. So I was able to look at their symptom scores and different clinical and demographic variables. But in terms of the symptom issues, So just some basic demographic data breaking it down, more males than females, and more patients in this cohort that were diagnosed that were over the age of 60, which is not uncommon with multiple myeloma. But there were almost a quarter that were under 60. And then where they lived. So most of the patients in this cohort lived in rural or metro areas. About 20% lived rurally or remotely. And then if you look at the symptom complexity, a pretty good chunk reported low symptom complexity. Now, this would vary depending on where the person was in their treatment trajectory, if they're getting treatment, if they're newly diagnosed. But, a good chunk still reporting moderate or high symptom complexity. And quite a few, half, having ER visits in the 6-month study period, only about a third having hospital admissions. And then in terms of the specific symptoms themselves, you can see that, oh, my apologies. Oh, where did that, so for some reason that it didn't come onto the slide, but I'll tell you that the top 3 happen to be on this chart. So there's meant to be another table here too that's disappeared somehow. But I can tell you that the top 3 most commonly reported symptoms and the most severe symptoms reported were pain, tiredness, and adverse well-being. So this is a bit of a funny one. It's reverse scored in some ways, I guess, because it says all the items on the ESAS ask you to rate your symptom at its worst, being the higher score being the worst. So tiredness, you can see there weren't a lot of people that had no tiredness. Tiredness was quite common and severe for quite a few people compared to the other symptoms, and pain as well. So most people had some amount of pain, mild, moderate, or severe. And then the impact on well-being as well was also felt to be quite pronounced. The other symptoms on there, I can see them on my other computer, were things like depression and anxiety. They didn't rank very high at all. And appetite and nausea were also ranked quite low. Again, you can imagine that might vary if somebody is on a different type of treatment that causes more nausea. But this cohort, the majority of patients reported that pain, tiredness, and adverse well-being were the most common symptoms. And as I mentioned, I'll just go back for 1 second too, because I think, well, it'll come up in this slide too, but there's been an explosion of therapies in myeloma over the past, 5-10 years for sure. Back in my day when I first started, we had chemotherapy, pretty standard chemotherapy, and then eventually stem cell transplant. And then, all these different things like the immunomodulatory drugs like lenalidomide, pomalidomide, and the proteasome inhibitors like bortezomib or Velcade and carfilzomib. And so we've really seen a shift in the way we approach myeloma. And the other little piece in here too that I think a lot of people sometimes don't recognize is that dexamethasone, which is a main component of treatment for multiple myeloma and is included in many of the regimens. Dexamethasone itself, well, not a chemo drug, it's a corticosteroid. It has potential to cause a lot of pretty severe side effects for a lot of patients as well. So things like insomnia, heartburn or dyspepsia, agitation, anxiety. The good news is, and watch the American Society of Hematology, or ASH meeting is coming up here the first week of December in San Diego. And I've seen some abstracts already that talk about potentially reducing the amount of dexamethasone that we use, and not having any adverse impact on outcomes in terms of survival and that kind of thing. So it looks like we might be able to get away with less dex, which would be good news because it's a tough medication to take. And so I think when we're thinking about treatment options too, there's lots of different medication options, but I also like to always remind people that observation and surveillance is also an option too. So, we don't have to always feel compelled to jump right into treatment. I think we're learning more about aggressiveness of disease and if there's bony disease or if there isn't, and how disease may progress. Is it going to progress mostly, biochemically in the blood markers and things, or are we going to see more bony disease? And that's quite individual in my experience anyway, and depends really on the patient. So I think that part, and then you'll see supportive care here in this diagram comes at the very end of all of this. And I would say supportive care really should be occurring throughout. So again, when we get into that language around palliative and supportive care, palliative versus supportive care, these kinds of medications, we're talking like lenalidomide or pomalidomide or CAR T, those are what we would call disease-directed or disease-modifying therapies, where we're intending to control, stop, or eliminate the cancer. And then there's the other things that we can do, the pain medications, the anti-nauseas, the anti-infective agents, the antibiotics and antivirals and things. And those would be more supportive care medications, and they are not mutually exclusive. So you don't do one or the other. You can do them both and should do them both at the same time. And yeah, it's just to highlight how complicated the treatment for myeloma is getting. It's exciting, but there are so many different treatment options now because we're learning more about the biology and pathogenesis of myeloma. So we know that there are different targets that appear on the cells of myeloma cells and that are not on the surfaces of healthy cells. So that allows us to target those bad cells and kill those bad cells and spare the healthy cells. And a lot of the intention behind our regimens and grouping drugs is that if we can target different, or if we can hit different targets, I should say, you can see that daratumumab here is targeting this receptor here. And then you have within the cell itself, things like venetoclax targeting BCL2, so a particular type of pathway. And so if we can target all these different pathways, then we can hopefully, that will lead to improved tumor cell kill and spare the healthy cells. And so it's been really quite remarkable to see the growth in terms of the understanding of how myeloma cells different from normal healthy cells. What that means, I would say, is it gets complicated when you're starting to think about treatment decision-making. Because even though these medications are very targeted, some of them can have very profound side effects and toxicities as well. So it really requires, careful weighing of those risks and balances, or risks and benefits, and trying to sort out, what the right treatment option is for you. And if you could put the poll up now, Corinne, that would be wonderful.
All right, so just take a few seconds on your computer or your phone. You should have a pop-up that just came in, or you can click on poll if not. So the question is, what is the first thing that comes to mind when you hear the words palliative care? So I'll give you a few seconds so you can locate, and I will then have a look at the answers. Coming through.
I should have had some catchy music. I won't sing, trust me, you don't want me to sing.
It's different because usually when I use polls, we have different a selection of answers.
Options, yeah, and they select, yeah. Oh, there's a comment that the poll didn't work. Oh, that's okay. So
on the iPad, maybe it's different on a tablet.
Yeah.
That's fine, as long as we have as many answers as possible. So
okay,
I'm just gonna end it for now. I saw one coming again, so 75% is enough. We're just,
that's good.
okay, let's share the answers. So so what are the words that come to mind for palliative care? So we have end-of-life care, terminal disease, end-of-life support and care, pain control, when there are no treatment options, sick patient, hospice, end-of-life, 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 death, end-of-life, comfort, like this one, providing comfort for end-of-life, comfort and support.
Yep, that's great. Thank you, everyone who was able to put in a comment. That's definitely congruent with what the literature would show. That's congruent with the research that I've conducted as well with patients, caregivers, and even hematologists and BMT nurses, who all said the same thing as you did, for the most part, that when they hear the term palliative care, they think very often of hospice, end of life, death and dying. And so that makes it tricky then, to, how would somebody expect to feel then if they were referred to what is thought of then as the death and dying service? You can imagine that could, evoke a very negative, potentially very distressing reaction. And it's not a surprise, because when palliative care, when that term was coined, and this is dating years back, more than 40 years ago now. And it was a Canadian physician actually in Montreal who coined the frame palliative care, meaning to comfort and to alleviate distress and symptoms. But it kind of was born or grew out of the hospice movement. So it's not surprising that people equate palliative care with hospice care. And that's, again, I think where that component or that piece of the definition where people think death and dying comes from. But in recent decades, even, there's been a shift in that definition. And the World Health Organization defines palliative care as an approach to care that improves the quality of life of patients and their families facing the problems associated with life-threatening illness, serious illness, life-threatening illness, or injury. But this is where it's changed a bit. So it's applicable early in the course of illness, in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications. So that could be, all things are on the table in terms of managing the quality of life there. So some people think that, if they get referred to palliative care, they can't have antibiotics, they can't have blood transfusions, they can't have surgery if they needed surgery. The difference would be that the focus of those interventions would be to provide relief and comfort rather than trying to cure the underlying problem. But at the same time, there is this kind of conflation of the two ideas, where now we know that palliative care and disease-directed, even curative intent treatment, those are not mutually exclusive. We can deliver those two types of care at the same time. We can and we should, because there's research now that shows that the outcomes for patients and their loved ones are better if we do it that way. So the goals of palliative care, and you'll hear me switch back and forth between palliative and supportive care, and there's debate in the research about this too, in the literature. Should we change the name of palliative care to something else, like supportive care? My preference is to not get rid of palliative care altogether, because there is definitely a role for that, but I think we have to change how we think about it. And in the meantime, until everybody is kind of on the same page about what palliative care means, I think including supportive care can help it not feel as scary. So my research study, I have a randomized clinical trial here it's in Alberta running, and our shortened abbreviation for it, palliative and supportive care, is PALS. So that's not as scary as palliative care. But research has shown that if we simply just change the name, then people would become afraid of whatever that new name is as well. So it's more about understanding what palliative care can do. And these are the main goals of palliative care, is really helping to optimize quality of life by making sure the symptoms and side effects of disease and treatment are really comprehensively managed. There can be assistance with practical concerns that might be, helping navigate the healthcare system to some degree, helping with referrals, especially in the community, once care at the cancer center is finished, or if there's a pause in care at the cancer center, or if the person decides they don't want to be coming to the cancer center anymore. So some coordination of care is really key there, helping address spiritual and existential concerns, and then again, providing that layer of support to family caregivers, friends, and other loved ones. This again is just to kind of differentiate the two types of care, hospice care versus palliative care. So, and in the United States, the definition of hospice care is a little bit different. So in Canada, we usually refer to hospice care as care that's provided in the remaining months of life, and it's often provided at a facility. So it's often facility-based care. Hospice care, palliative care, though, can be provided anywhere, and there's no specific time frame. It's not tied to a prognosis. It's more tied to patient need. So we don't have to say someone only has a few months to live. We can say, no, they're having a lot of pain and other symptoms. This is somebody who needs palliative care. And that is true for anybody with any type of cancer. And again, even if we're intending to cure that cancer. The interdisciplinary team is really key for both types, both palliative care and hospice care. And now there's a real big push, and a lot of cancer centers throughout the world are starting to integrate palliative care from time of diagnosis. And that is to really help optimize quality of life and make sure we're really attending to all the needs that the patient and their loved ones may have. And again, the hospice care definition would be mostly reserved for end of life care or end stages of life. Both types of care really aim to provide optimal quality of life for the patient and support patients and caregivers. So who provides palliative care? Ideally, in a perfect world, we would have this nice multidisciplinary team. And in the urban centers, this often does look like this, where we have spiritual care, we have social workers, psychologists, physicians, nurses, physios, and occupational therapists. In the rural and remote settings, this is much more difficult. And then a huge part of palliative care is provided by families and loved ones. And you can see there in the middle the types of needs that might arise. So really having that multidisciplinary type of care to address the multidimensional aspects of suffering and distress that can happen after a cancer diagnosis is really key. These cartoons were created by a palliative care doctor in the United States, Dr. Nathan Gray, and he did a bit of a Richard Scarry kind of take on different palliative care clinicians and their roles. And so, as I mentioned, ideally we would have all these different team members as part of the palliative care team, but in reality, this doesn't always happen, especially in rural settings or remote settings. The use of telehealth is perhaps a bit of a silver lining of COVID. So we did, of course, have to shift to virtual care for a period of time at most cancer centers. At least some care was provided virtually. And at our cancer center in Calgary, we continue to provide virtual care. And one of the happy side effects, I guess, of that is that we can reach people in rural and remote areas and still try to provide that multidisciplinary type care and not require the person to have to come all the way into the cancer center to do so. So when should palliative care be provided? Well, I can tell you when I started in cancer care, this was the model that we basically followed. So we would do treatment until there was no evidence of disease, or if it was a curable cancer. And we would have supportive care happening all along. And that might be things like antibiotics to prevent infections and things like that. And then as soon as the cancer was considered incurable, then we might start talking about palliative care, not always at that point, but sometimes we would. And then right at the very end, we would have hospice care. And then of course, bereavement care after someone passes away. But the new model is that we should really be integrating palliative care earlier on. And then it increases, and I wouldn't say necessarily at the end of life, because for anybody who's gone through stem cell transplant, that's a very intensive type of treatment that has, or even CAR T cell therapy now, and BiTE therapy can have a lot of side effects. That doesn't mean the person is close to the end of their life. It just means that the need for palliative care and really good symptom management is really high for that person. And so, if we look at this previous model and we only waited till the end to integrate palliative care, then we have this huge part over here of intense symptom experience, psychosocial distress, physical distress, that we could be intervening earlier and improving quality of life and improving that experience for the person and their loved ones. So even palliative care even plays a role in survivorship. So if somebody, has a type of cancer that is cured and they go on to the survivorship phase, there's still a role for palliative care because, as we know, many of our cancer treatments leave residual or long-term or late side effects. Neuropathy is one for sure in myeloma that we see that can persist for years beyond the cessation of treatment with something like bortezomib even. And so there really is a role for palliative care even in those settings. And again, there is a role obviously at end of life, and you can see how hospice fits in there too. But I hope you'll realize that palliative care and hospice, they're not the same, and that disease management or disease-directed treatment, where we're trying to control or eliminate the disease, it's not mutually exclusive. So we can still have palliative care, pain and symptom management. It doesn't have to be one or the other. And again, as I mentioned, palliative care is something that can be provided in any setting. So it could be provided at home, and it often is. We have, again, this is sometimes restricted in the rural and remote areas, but most of the urban centers have pretty well-established home care teams, including palliative home care. And the hospital and clinics should have this as well, especially in urban centers. Long-term care and supportive care living facilities often have their own in-house experts, or they can bring in a consultant. And then, of course, hospice facilities. And this is an example down at the bottom of the screen of a hospice facility just south of Calgary. And it's on about 5 acres of land. This is the view from pretty much every patient room. And that would be a setting there that would be more intended for end-of-life care. So this diagram just shows, again, the type of models of care, and this will vary depending on where you live, whether it's an urban center, rural, or otherwise. But in most urban centers, we have acute care facilities that have a consult team of experts that can, doctors and other healthcare providers in the hospital can contact the consult team. The patients can be seen in hospital or in the outpatient setting as well. In community-based care, there may be outpatient clinics at the Tom Baker Cancer Center. We don't call it the palliative care clinic; we call it the pain and symptom clinic. But it's intended to really offer that comprehensive pain and symptom management, especially for complex symptoms. And again, you're seeing in this diagram that we're recommending that there should be, consideration of integration of these teams and services from the time of diagnosis. The American Society of Clinical Oncology talks about advanced cancer or those with high symptom burden, and patients with blood cancers often have high symptom burden, and those are the patients who can really benefit from early palliative care. So this, I hope, will really bring home the message of why I'm hoping that I'll shift your mind about the thoughts of what palliative care is and what it isn't. So we know that if we integrate palliative care earlier on in the disease process, that symptom management is better. Quality of life is better because presumably because symptoms are better managed. Patients understand the illness and treatment expectations. There's better understanding of both. Prognosis as well, caregiver outcomes, so mood and anxiety, depression, things like that can improve for patients and caregivers. And then we know also that if palliative care is integrated earlier, at least for patients with solid tumors, we see that there can be less aggressive care in the last month of life. So that would be usually the last 30 days, where there would be things like being admitted to the ICU, having aggressive chemotherapy or different procedures within the last few weeks of life. And then there are some studies that actually show improved survival if we integrate palliative care earlier. We also know that if we don't integrate palliative care early, we deny people often the ability to consider even going to hospice, because a hospice referral to go to one of those facility-based hospices can take a few weeks sometimes to coordinate, that we may not be maximizing or optimizing the family and caregiver support available. We might not be as comprehensively managing pain and symptoms. And we miss having some of those conversations about goals, wishes, and values. So what are your hopes for what are your hopes and goals for treatment? What are you hoping to get out of treatment? What would be kind of a no-go in terms of, some of the negative aspects of treatment? If there was a treatment that might extend life by 2 weeks, but you'd have to be in hospital for all those 2 weeks, is that okay? Is it worth it? And that's only a decision that the patient can make, in conjunction, of course, with their family and loved ones, but it's the patient who's in the driver's seat for that decision for sure. But this is part of what palliative care can help to do, is just to talk through some of those. And often it's not even talking, it's just listening, letting the patient and their loved ones talk. And then we will see sometimes if we don't integrate palliative care early, we can see overuse of chemotherapy and different aggressive interventions at the end of life. It's challenging with blood cancers because sometimes they will remain very sensitive to chemo or treatment right up until the last few weeks, and it's really hard to predict what that might look like. So sometimes we do have people who have treatments, and sometimes different types of chemo, especially now that we have quite a few different oral options or pills that people can take at home. Provided that the side effects from those pills aren't too bad, it might be that that pill, even though it's a chemotherapy pill, is really providing good symptom management. And so I don't always think that some of these things are necessarily a bad thing for patients with blood cancers, because blood cancers are quite different than solid tumors in many ways. It's just, are we doing our best to make sure that the treatment that we offer is aligned with what the patient wants? As I mentioned, the American Society of Clinical Oncology released some guidelines on integrating palliative care into standard cancer care. And they recommend integrating palliative care for patients with advanced cancer or those who have high symptom burden. In this paper, and this is a few years old now, it's 7 years old now. I think there was an update in maybe not. I thought it was 2018, but maybe not. They do mention that many of the clinical trials to date have focused on patients with solid tumors, and there's a need for more research to be done on patients with blood cancers, and also a huge need to look at how palliative and supportive care can support caregivers as well. So this is the seminal study, I guess, that really changed how we think about early integration of palliative care. And it was done in the States in Boston. And Jennifer Temmel and her group, she's, I guess, now a very well-known palliative care researcher, and she's done a lot of work in cancer care and palliative care. And this study was for patients with advanced non-small cell lung cancer. And they looked at these patients. They randomly assigned them to receive either early palliative care or standard care. And then they followed them for 3 months. And you can see in this graph here, these graphs, that the patients that were referred to early palliative care, it's kind of this, I don't know what color you would call this, but not the blue, this burnt orange color perhaps. They had reduced symptom severity, mood symptom severity compared to the patients who had standard care. And then if you're looking at some of the different, this was the functional assessment of cancer therapy lung, the FACT lung scale, and they looked at symptom scores. And the patients at 12 weeks or 3 months had fewer depressive symptoms, and overall they had better quality of life. And they also looked at survival. So this is the survival curves. The patients with the early palliative care actually lived longer, and it was statistically significant than the patients who only received standard care. And it was not a huge difference, but the patients who had early palliative care had a few months. It was 11.6 months compared to 8.9 months for the patients with standard care. So that would really shifted how we thought about palliative care, because it wasn't that we were providing a particular drug to this group or anything. It was just that extra support, and it actually helped improve a number of symptom outcomes, but also improve survival. So since then, there's been an explosion of studies looking at early palliative care. This is a busy slide. I don't expect you to even read this, but just to say that the green favors palliative care. The yellowy, orangey colors, they didn't show significant differences. But some of the studies did look at symptom scores, some looked at survival, and overall, the majority of studies found improved symptom scores. Survival was not always different or better necessarily. So I think, the jury's still out. But again, most of these studies were done in patients with solid tumors. Very few, like this one includes solid and heme malignancies, and so does this one. But again, you can see that there's a lot of green on this screen. So really suggesting that early palliative care and integrated palliative care can be beneficial for patients. And what is it exactly about integrating palliative care early that's leading to especially the survival outcomes, I think, is a compelling question for a lot of us. A lot of us want to know, what is it with about the palliative care that leads to better survival? And we don't really know for sure. There's some speculation that it might be better symptom management, and that might allow people to stay on treatment longer with fewer breaks or interruptions in their treatment. And that might lead to better survival. But it also might be that there's more discussions between the patients and their clinicians about their goals and wishes for care. We know that sometimes aggressive care, like aggressive treatments, can actually increase risk of dying and increase the risk of complications and things. So, we don't know for sure exactly what it is, but we do know that if we integrate palliative care, and again, this is less tied to prognosis and more tied to patient need. And that's why this author or this group of authors considers it to be timely symptom management, not necessarily early palliative care, but timely palliative care and timely symptom management. So tailored to the patient's need. And then really, long-term psychosocial support for the caregiver as well. And then perhaps that leads to better decision-making and, better discussions about medical decision-making, and also more discussions about end-of-life care and wishes for end-of-life. So we know from the research that caregivers also experience a lot of distress when their loved one is diagnosed with a blood cancer or any type of cancer. And if we're integrating palliative care earlier, the research suggests that also can help caregivers cope with the caregiving experience better. And that might be something like explaining how the illness and the treatments or the medications work, or helping to teach ways to manage different problems as they arise. It might be helping to promote self-care for the patient or for the caregiver, sorry, because very often the caregivers will put their own needs on the back burner, and they neglect their own health and well-being. And then it's a link or a partnership then with the caregiving team and the medical team, and then helping again with decision-making and support, providing or linking up the caregivers to counseling and other services such as respite care if they need a break from caregiving, helping with some of the practical concerns that can arise. So the care coordination and navigating some of those practical challenges, and then assisting with advanced care planning. And I'll talk about advanced care planning in a minute here. And I'm almost done, I promise. So just again, from our own research, I just wanted to share a few quotes. So this was from a study I did in 2020 and 2021, where I interviewed patients, caregivers, and BMT clinicians about their thoughts about integrating palliative care for patients with blood cancers. And just hearing some of the spouses' comments and quotes, just saying, we need more supports for the caregivers. The caregivers are going through a lot too. And this particular spouse said, when I run into someone now, they always ask, how's the patient doing? I'm so glad he's doing better, but I rarely get asked how I'm doing. And this patient or spouse up here said, I've had a lot of physical symptoms in my own body arise from the extra anxiety I feel now all the time. So the caregiving experience can be quite intense, and it can be quite prolonged as well. So we need to integrate more supports for caregivers throughout the disease and treatment trajectories. Advanced care planning, and this is something that I know happens, and the language might vary across the country, but advanced care planning is basically just thinking and talking about your wishes for care, the goals of care designation. We used to call these things like code status. That's a specific medical order that's used to describe and communicate the focus of care and the preferred location. So it might be that someone says, I never want to go to ICU. That would be included in such an order. And again, the terminology varies across the country to some degree, but just thinking about your wishes and doing this at a time when you're healthy and well, or well enough to have these conversations, can be really helpful for you to make sure you get the care you want, but also for your family, because making decisions at a time of a medical crisis is really difficult for everyone involved, and it puts a lot of pressure on the caregiver as well, or the agent, or the near person who's going to be making decisions for you. So again, like I said, it might seem morbid to talk about things like this. I've had these conversations with good number of my family and friends. And it might be uncomfortable to think about this stuff, but it really is a gift for everyone if you can make these decisions in advance and not wait until there's a crisis. So it's just like if you think about taking a long car ride, a long road trip, you know, you're hopeful nothing's going to go wrong, but you know, there may be some challenges or bumps in the road. And the goal at the end of this is you want to make it to your destination safely. If you think nothing will happen, it's Murphy's Law, you know, you're not prepared, something could happen. So it's the same through the course of care as well. So, you know, if we put these comfort measures and options in place, then hopefully we'll have improved symptom management, better quality of life, and the outcomes will be better as well. It doesn't mean that we're substituting one outcome for the other necessarily. It just means that we're wanting to get there in a smoother way, with fewer bumps in the road. And so, yes, I think that's about all I have to say about that. But I would love to have some questions, if there are any. And also just to point out some resources here. And as I mentioned, Myeloma Canada has some great decision-making tools on the website. The International Myeloma Foundation has a good section on palliative care on their website, My Myeloma Team, the American Society of Clinical Oncology, and then not to muddy the waters with talk of hospice, but there are some great resources on virtual hospice, resources for family members and friends and for kids even, resources about grief and not necessarily exclusively related to death or dying, but about how to, you know, make sure that you have the supports in place that you need. So I'll stop there and I'm happy to answer any questions, or if anyone wants to share their own experiences of palliative care or lack of palliative or supportive care, or your own thoughts about how we should best provide support to patients. I'd love to hear your thoughts. Thanks very much.
Thank you so much, Rianne. I think it's pretty encouraging to see that patient can have access to palliative care for managing the symptoms. That's very good. My first question would be actually, and it's my question, but so do patients need to fill a form or ask their doctor about it, or is this something that the medical team would offer to the when they feel that the symptoms are pretty high or tough?
It's a great question. So the research shows that if we wait, it's funny because I also have done a lot of work in the field of sexual health and intimacy and cancer. And the literature is very similar in both fields, that if we wait for patients to ask for referrals, patients are sometimes reluctant to ask for referrals. And then we end up in a situation where it doesn't get done, or if it gets done too late. And so, ideally, we would equip the hematology nurses and doctors to be able to recognize triggers to say, this is when we should be thinking about bringing in palliative care. In the meantime, while we're doing that hard work of educating clinicians to say palliative care can really help and provide an extra layer of support for patients and their loved ones, patients can definitely ask. You can ask to talk to, and again, it varies across the country what the clinic or service might be called. It might be called the palliative care clinic. It might be called the advanced pain and symptom team or the complex pain and symptom team. At most of the major cancer centers, there will be somebody with that expertise. Again, like I mentioned, in the States and other parts of the world, they have embedded palliative care clinics right within the cancer center. And it's easier to just, you know, the nurses or other people can easily refer, or patients can ask for referrals as well. So it's coming. And my goal, my ideal would be to have an embedded palliative care specialist working with the hematology teams to be able to say, you know, we know that this particular regimen, you know, if it's teclistamab, if it's, I'm not picking on you, teclistamab, but if it's CAR T or BiTE, or, you know, if it's stem cell transplant, we know that those treatments have a lot of potential side effects. That could be somebody who could benefit then from an early palliative care consult to say, you might not have any issues. You might not have any bad side effects or symptoms or issues. You might sail right through. But if you do have problems, here's a number you can call 24/7, and you can get extra support if you need. That's my ideal.
Thank you. You were talking about advanced care decisions. So just to mention for people living in Quebec, there is something on the website of the government of Quebec. It's called Advanced Medical Directives. So people can log in and actually put their decisions regarding the care that they wish to have in the future. So that's something we can do far away in advance, and it's pretty useful. I guess, it's different from one province to the other, but it's pretty important to let your family and loved ones know about what you would like to have as far as care.
Yes.
So
Yeah.
I will go with the questions now. So
And I'll just, as you're doing that, I'm so sorry.
Sure.
My final slide, I didn't have my final slide. I thought something was missing. So I'll just zip through,
Sure.
but just to summary, we know that palliative care can help improve quality of life for patients and their loved ones. It can and should be part of routine cancer care. And my bias is definitely in the research shows from time of diagnosis through to bereavement, and how that looks for each patient might be quite different, depending on their need. Palliative care can help with pain and symptom management, psychosocial symptoms as well, mood, anxiety, depression, existential suffering, advanced care planning, supporting the whole person. And I like to think of it this way, and I've heard this from so many palliative care doctors. Palliative care helps people live as well as they can for as long as they can. And I don't like to hear, and I hear this so often, there's nothing more we can do for you. And that's often a phrase used when there's no more disease-directed treatment options. But I think, and I'll always believe, that there's always more we can do. We can always help manage symptoms and improve quality of life. There's always so much we can do so that people don't have to be suffering.
Very good.
And yes, I see questions too, so I'll let you read the questions then, if that's okay.
Sure. So what are your views of MAID, which is, I'll just clarify, I guess it's the medical assistance in dying, correct?
Yes. Yep.
Okay, so again, to the question. So what are your views of MAID as an alternative to palliative care?
Yeah, so you know what, when MAID was first introduced, a lot of palliative care clinicians didn't like that it kind of got lumped in, and in provinces do this differently. So in some parts of Canada, they are more integrated, where palliative care clinicians are the ones that do the assessments and provision of MAID. In some other provinces, they're very separate entities. I think that MAID, and I do assessments for the MAID team here in Alberta. I do eligibility assessments to see if somebody is eligible for MAID. And I think that it is part of the toolbox. My belief is that a lot of the physical suffering that can happen with advanced disease and even towards end of life, we can do a great job at managing physical suffering. It's harder to manage existential and psychosocial suffering. So a good number of the patients who requested MAID in Canada, the most recent reports will show some of it is because they were worried about pain and symptoms, but a good chunk of it is that they worry about being a burden on their friends and family. Another big part of the reason people request MAID is because they have lost the ability to enjoy their lives, or there's less meaning in their lives. And it's tough. If somebody is stuck in a bed or a chair all day because they're so physically unwell, there's not a quick fix for that. We can't give a pill to magically give them back all their energy, and now suddenly they can do all the things they want to do. So it's tricky. So I think that MAID in Canada offers an option to people who experience distressing and unrelenting suffering. And my hope is that would or should be a very small number of people, because I do believe that we should be able to provide very comprehensive palliative care that should be very good at reducing or eliminating a lot of suffering associated with advanced disease and death and dying.
How is the palliative care notably different than our primary doctor care in terms of symptoms management?
That's a great question. I think a lot of primary care providers are excellent at palliative care. There are a lot of oncologists that are excellent at palliative care. And then again, it depends on the person's expertise and training. But that being said, I would suggest that there's a lot of support for family doctors. And I would love to see more supports built in for family doctors if they needed to reach a palliative care expert to be able to help with symptom management and things like that. but family physicians, again, are main pillars of care throughout the cancer and blood cancer illness, disease, and treatment trajectories. So if you have a really good family doctor, I would say that person probably is ideally suited to be able to manage. And if they can't manage the pain and symptoms that might happen, then certainly they could liaise or work with palliative care experts in the community to help.
Support groups sound like they would fit into a definition of palliative care. Is that correct?
Yeah, I think it depends on the aim of the support group. So some support groups provide more information about disease-directed treatments and different things like that. But yeah, anything that alleviates symptoms by nature is palliative care. Snuggling my little wiener dog, that might be a type of palliative care as well. So I think if the intent is to alleviate distress and help improve quality of life, then it probably falls under that broad umbrella of palliative care. But it would just depend on what the goals of that support group are.
Okay. What if you live alone and have no one to help you?
Yeah, and that's something I'm seeing in our research too. So, there are a good number of patients in this large cohort of patients that were unpartnered at the time of study participation. And we worry about people who live alone for sure. So that again is where, if we can support somebody who's living alone with, if they've got a network within their community, that's great. But if they don't, and during the times of COVID, that became very challenging for sure. But linking up with community services if they're available, and if not, then seeing what services exist at the cancer center that they might be able to provide some remote support. But definitely one interesting thing that came out of that study, and not just to the patients with myeloma, but there's a correlation or relationship between patients who are married and patient and hospital admissions. So I thought it would be the unmarried or single patients that would be admitted to hospital more often, but it isn't. It's the patients who are married. And I think that part of the explanation for that is that they have an advocate. They have someone to see if things are kind of not going well and that person needs help and they need to go for hospital admission. And so that kind of makes sense to me. And then I worry about the people who live alone. So I would say, linking up with community resources, if those are not available, then really linking up with the tertiary cancer center to see what supports and services they might be able to provide, even if it's virtual or remote.
Right, I think that's all we have for now. Oh, hold on. You did not answer my question. Okay, so we do have one more question regarding myeloma specifically but I think I will just leave that for a separate answer because it's not really related to palliative care, but mostly myeloma. So don't worry, Mrs. Paul, or Mr. I'm sorry. I will make sure to answer a question appropriately by email to give as much information as possible on myeloma. So if we don't have any more questions, I think we will end the session for now. We went a bit over 6 minutes, but I'm happy that we could answer as much information as possible to give as much support as possible as well. So again, this session was recorded. I hope that you will go back to our YouTube page and watch the information again so that you're well informed, and pass it along to other patients that you know that would benefit from this recording as well. Thank you again, Ryan, for your time today. And I'm sure if ever some other questions come up, in any case, within a day, I think you will be receiving by email a little survey to answer so that I can take some comments and other questions. So if ever I can forward those questions to Ryan to have more explanations on different specific topics
Absolutely.
for today. So
thank you. Wonderful. Yeah. Thank you all for attending. Thanks for having me, and keep well. And yes, happy to answer questions anytime. And I'll send the slides to you right now.
Perfect. Thank you and have a great day.
You too. Bye-bye.